Hello everyone. With the surge of COVID cases in the second wave of the pandemic, a large number of children have been infected, and proportionately, a large number of children are reporting back with the multisystem inflammatory syndrome in children across the country. In this brief video, I shall touch upon the diagnosis and management of this syndrome, the current perspective. Multisystem inflammatory syndrome occurs typically 4 to 6 weeks after infection with SARS-CoV-2. It's an immune-mediated phenomenon. So if children have recovered out of COVID, for the next 2 months, parents must observe for the signs and symptoms that I would mention in this video. This is an uncommon disease. As per a study way back in 2020, 322 children were infected with COVID-19 out of 1 lakh, and only 2 of them developed MISC. So less than 1% of children who recover COVID may develop multisystem inflammatory syndrome. Because it's an immune-mediated phenomenon, antibody test is positive in majority, while only a few of them are coming with acute COVID and PCR being positive. The clinical presentation is very characteristic. Young children below the age of 5 are presenting to us with the Kawasaki disease phenotype. They come with high fevers, red eyes, rashes, red lips, red tongue, and high CRPs and rising platelet counts. This is the KD phenotype. While the older children are presenting with high fevers, rashes, red eyes, some of them have severe pain abdomen and cervical lymphadenopathy. Again, very high CRPs have been noted in these patients. Lymphopenia is a consistent feature, and some of them present with low blood pressure, and this shock is due to severe myocarditis. This is the MISC phenotype. A small number may just have fever, rashes, and high CRP, no organ dysfunction. This is the febrile inflammatory state, and the third group must be closely observed, while the first two groups must be treated actively. Compared to the classical Kawasaki disease, the MIS-C has got some distinct features. Classical KD would occur below the age of 5. Shock was an uncommon phenomenon seen less than 5% children. Myocarditis was often subclinical and the trigger was unknown. While in MIS-C, most children are above the age of 7. Shock is seen in more than 50% of children. Myocarditis is clinically manifest and trigger is COVID-19. So you can clearly see the MIS-C phenotype looks much more sicker than Kawasaki disease. The good thing is both of them are responsive to steroids and intravenous immunoglobulin. Unique features attributable to MIS-C when compared to KD are that there is a clear link with COVID-19 infection in MIS-C. GI manifestations have been very prominent. CNS manifestations like abnormal behavior, headache, and meningism has been noted in a large proportion of children. And interestingly, bradycardia during recovery has been noted in a few patients. The close mimics must never be forgotten. When you see a child with high fever, rash, these differential diagnoses of toxic shock syndrome, tropical infections like dengue, malaria, or rickettsia, viral myocarditis, and early phase of rheumatologic illness like systemic GI or SLE may be a close mimics. And whenever we make a diagnosis of MIS-C, these differential diagnoses must be kept in mind. And that is why most of these children should be given broad spectrum antibiotics at admission. Why does this happen after 4 weeks of SARS-CoV-2? What's the pathophysiology? Clearly, this looks like an immune-mediated injury. There are several hypotheses. One of them is as follows. When somebody is infected with a virus, you develop an immune response. You get neutralizing antibodies, which shall block the entry of virus into the cell and also try clearing the virus. However, a proportion of these children develop what is known as non-neutralizing antibodies, which would bind to the virus and cause enhanced uptake of virus into the macrophage. The macrophage is now converted into a pro-inflammatory macrophage, driving a cytokine storm. This is called the antibody-dependent enhancement, and that is possibly the reason behind multisystem inflammatory syndrome. The lab features are very classical. Marked elevation of CRP, sometimes as high as 300 milligrams per liter, is noted. Lymphopenia is a very consistent feature. Though ferritin is elevated, it is usually between 1000 to 2000. And if you have a child with very high ferritins, above 10,000, cytopenias and hypertriglyceridemia, think about macrophage activation syndrome. All these children must be subjected to an echocardiography, and myocarditis with myocardial dysfunction may be noted, while 10 to 20% of these children may develop coronary dilatations or aneurysms. Now, typically, either the SARS-CoV-2 is positive or antibody test is positive, or at least there is a contact with a positive case in the last 4 weeks. But then the COVID-19 tests have to be interpreted very carefully. During the first wave, the antibody tests were not readily available. During the second wave, antibody tests are available, but they may not always guide the diagnosis as the disease is rampant in the community. And we are seeing a lot of children who do not have MIS-C but have COVID antibody test positive. And hence, COVID antibody test positivity does not mean multisystem inflammatory syndrome. And again, exposure to COVID 19 does not have much significance in the current scenario, as children may have come in contact with asymptomatic adults, and that is why the history of COVID 19 exposure may or may not be present. Now, look at this case, a 4-month-old child, fever for a month, COVID antibodies positive. Is this MIS-C? The answer is no, because typically the duration of illness in MIS-C is less than 2 weeks. So, having fevers plus COVID antibody positivity is not multisystem inflammatory syndrome. Now, what is the role of interleukin 6? Now, IL-6 is produced in the liver. IL-6 is produced by the innate immune cells, and it drives the production of CRP in the liver. Now, typically, IL-6 is elevated in infections and inflammations, and CRP is a good marker. So, I would clearly say IL-6 has no clear role in diagnosis or therapy, because CRP itself can be used for therapeutic monitoring. Now, what is the role of D-dimer? D-dimer is a marker of endothelial cell activation. Elevated D-dimers can be seen in infections like dengue, toxic shock syndrome, sepsis with DIC, systemic GIA. So what does it mean? It means that D-dimer is not diagnostic of MIS-C, and fever with elevated D-dimers is not always MIS-C. Now look at this child from Hyderabad who is a 10-year-old boy who had fever for 3 days, then went on to have low-grade fever for next 7 days. COVID PCR was positive, D-dimers were elevated 1500, CRP was negative, echo was normal. And this child was advised IVIG and anticoagulation because the D-dimers were elevated. Is this correct? No, because this is mild COVID infection. Basing the treatment just on elevated D-dimers is not appropriate. There is no role of IVIG or anticoagulation in this child because the CRP is negative and echo is normal. What is the role of CT chest? There is no or limited role of CT chest in MIS-C. No CT chest was done in any case of MIS-C at our center, both in the first wave and in the current wave. MIS-C is a multisystem disease with significant cardiac involvement. Lung involvement is sparingly noted. Pleural effusion may be seen, and CT chest does not guide diagnosis or therapy. Now, how do you diagnose these patients? Clinical features are very important in making a diagnosis. The first group, that is fever, rash, conjunctivitis with high CRPs, the younger children, they are typically the KD phenotype, and these KD phenotypes should be treated just like a child with Kawasaki disease with IVIG. On the other hand, the second group of children, who are older children, sometimes are just presenting with fever and cervical lymphadenopathy. Some of them have only fever and red eyes, but then if they have remarkably elevated CRP, a high D-dimer, lymphopenia, get an echo and pro-BNP. And if the echo is showing myocardial dysfunction or the pro-BNP is elevated, you know they are dealing with MIS-C. But the third group is the most tricky group, where you have fever, high CRP, but no organ dysfunction. And this is febrile inflammatory state. And these patients should be again evaluated in detail, get an echocardiography, but then they need not be treated with immunomodulation unless they have organ dysfunction. Mind you, again, majority of them will have a positive COVID antibody test. The treatment. Look at the KD phenotype, typically treated with IVIG 2 gram per kg. If it is refractory, that is beyond 24 to 36 hours, if the child continues to run fever, we would add IV methylprednisolone 2 mg per kg per day for the next 3 days, followed by oral steroids 1 to 2 mg per kg per day for 2 weeks, and then would taper. Aspirin would be added in all these patients, 5 mg per kg per day, the antiplatelet dose for 4 to 6 weeks. The second group, the MIS-C, which is typically presenting with myocarditis, and especially if they present with shock. Now, this is one group where we would not only treat with IVIG, but IV methylprednisolone. And especially if they are sick and having hypotensive shock, we would add high-dose steroids, 10 to 30 mg per kg per day for the next 3 to 5 days. And if after 5 days of steroids, children remain unwell and are refractory to therapy, injection tocilizumab or infliximab may be considered. Now look at this. MIS-C refractory to IVIG and IV methylprednisolone is not a common occurrence. This is a rare occurrence. However, if you get such a patient and if coronary aneurysms are present, we may use infliximab. On the other hand, if you have a MIS-C who is refractory to IVIG and IV methylprednisolone and there is myocarditis and MODS, we would prefer injection tocilizumab. Again, there is no role of repeat IVIG. Injection tocilizumab, the dosage is 12 mg per kg if the child is less than 30 kg, 8 mg per kg if the child is more than 30 kg, and the maximum dose is 800 mg. Injection infliximab, 5 mg per kg. Now, how do you taper steroids? A very burning question. At discharge, prednisolone, if you have started steroids in a given patient, they must be discharged on steroids 1 to 2 mg per kg per day orally. After discharge, you can repeat CBC and CRPs after a week. And if the CRP is negative, we start tapering steroids after a week. And we would usually stop it in next 2 to 3 weeks post-discharge. Anticoagulations. Please remember, high D dimers is not equal to anticoagulation because elevated D dimers can be seen in a large number of conditions. Now, the American College of Rheumatology has clear recommendations of anticoagulation in MIS-C patients if the ejection fraction is less than 35%, if a patient has giant coronary aneurysms with Z-score is 10 or above, or if there is documented thrombosis, one must use anticoagulation. Typically, the low molecular weight heparin would be used. Now, if you have obese adolescents who are presenting with shock and very low ejection fraction, this is one group better to consider anticoagulation. How long should you anticoagulate them? The duration is 2 weeks post-discharge, and thrombocytopenia is a contraindication to start this therapy. Now, aspirin should be given to all children 3 to 5 mg per kg per day for 4 to 6 weeks, and this must be avoided if there is thrombocytopenia, and this is again as per the ACR recommendations. Echocardiography is done typically in all patients who have been hospitalized at discharge, 1 week post-discharge and 6 weeks post-discharge. More frequent echo may be necessary in case of moderate to giant aneurysms. Now, over the last 10 days, we have seen 7 patients. In fact, yesterday, one more patient was hospitalized with MIS-C in our hospital. But we are typically seeing 2 groups. I would call the young group and the old group. Look at the young group. Typically, all of them are below the age of 5. They present with fever, rash, red eyes, lips, and tongue. Normal blood pressure, ejection fraction is normal. The typical KD phenotype. Now, here, these patients were treated with IVIG, and some of them needed additional steroids. COVID antibody was positive in all. The older group was typically much more sicker. They typically came with fever, cervical lymphadenopathy, abdominal pain, and all of them presented with shock and low ejection fraction. In this group, we had to use IVIG and steroids in all. While COVID PCR was positive in 1, COVID antibody was positive in 2. So please remember, older children are coming with the hypotension and myocarditis phenotype, the younger children, the KD phenotype. IVIG is necessary in almost all of them. The take-home message, a large number of children are likely to develop MIS-C in the next 2 months because there has been a significant surge of infections in the community. And that is why in the next 2 months, we anticipate a large number of children in the country would develop this syndrome. If a child presents with high fever, red eyes, rashes, pain abdomen, cervical lymphadenopathy, please think about MIS-C. Timely treatment is life-saving. One should treat the patient and not the individual test. Thank you. Take care. Stay safe.